Patrick, welcome. How are you?
Hi, I'm fine, thank you. How are you? Good evening to everyone.
Good evening. Thank you so much for presenting again. We're so excited to have you back.
Yeah, I'm excited too to be back. I hope everyone has some tachyarrhythmias already in anticipation.
Um, let's give it maybe 5 more minutes, Patrick, just so we can give some more people time to join. I'm going to send reminders that the meeting has started on WhatsApp.
Okay, no problems. All right.
And then for those of you who are already here, the baseline multiple choice questions are posted. If you would like to try them out, that would be wonderful. Thank you so much. All right, everyone. Thank you so much for joining us today for CMES Journal Club. My name is Jess Pelletier, and I am the Medical Director for Techies Without Borders. We would like to welcome Dr. Patrick Aleka, who is joining us again today from South Africa. For those of you who were here a few months ago, Dr. Aleka gave us a wonderful presentation on tachydysrhythmias, and we spent most of that session going through some examples of what those different types of tachydysrhythmias were. And we talked about wide versus narrow, regular versus irregular. And today, Dr. Aleka is going to continue talking about those EKGs with a brief review of different types of tachydysrhythmias, and then he'll go over the management and as well as some current literature and guidelines. And with that, I'm going to allow him to take over. Again, thank you so much, Dr. Aleka. Take it away.
All right, thank you, Jess. Welcome, everyone. Thank you for joining again. So the last time it was quite a lengthy tachyarrhythmia session, I remember quite well, and we couldn't get through everything. So this time I think we'll just quickly see if we can, complete the remaining part, which was basically management, and then we look at guidelines, some few guidelines, like Jess said. The thing is, it's not going to be all encompassing because there's just too much, there's just too much to. So I'm just going to really touch briefly on a lot of things. Most of them will be I won't delve too much, and then there'll be some room for extra, reading up around some of the concepts which we will touch on today. Okay, so I'm just going to try to share my screen now and see if we can get into the presentation itself. So, okay.
Patrick, it
I'm not
should
sure.
have screen sharing enabled.
Yeah. Can everybody see my screen now?
Not yet.
No, not yet.
No, not yet.
All right. Let's see. I just need to get there quickly. Jess, do you have the same presentation? Are you able to share it from your side?
I do have it. It might make it hard for me to moderate the chat if I'm also sharing the screen. Let me try changing the screen sharing settings one more time.
Let's see.
Okay, if you try clicking share screen again, please.
All right.
When you click share screen, it should have a pop-up and ask you which window you'd like to share.
Yeah, okay. So,
Are you getting an error message when you try to click share screen?
yes. Let's see. Let me try it now. Share screen. Yeah. Okay, I'm sharing screen now. Share entire screen.
Yay, it's working now. Wonderful.
Okay, fine.
Right now, it looks like you're sharing your Zoom, so we can't see your presentation.
My Zoom now. So let me go to the presentation. Yeah.
That's it. Perfect. Thank you.
Okay. Yeah, so welcome everyone. Learning objectives. We'll go through some learning objectives. We'll have a brief recap, and then I have a few cases that we will just go through. That will help us talk about the management using the cases. Right. Yeah, so the recap. I like the fact that Jess had put out the questionnaire just to set the tone. So we'll just quickly look at that. We talked about last time. We differentiate them based on four broad, categories like narrow, regular, and then wide, depending on how the QRS is. So I'm just going to share a few ECGs, and then we tried to make it interactive last time, and I think it really helped. So I'm not sure if we can still do that today. I'll just put across an ECG, and then we just run through it together with the same guidelines. Is it narrow? Is it regular? And then we try to have some differentials for it. Jess, is that fine? Can we make it interactive, or I just go
Oh,
ahead
yes.
and...
No, we would love for it to be interactive. So everyone, when Dr. Aleka asks questions, if you could please feel free to either chime in the chat. Thank you, Gina. You already answered his question. Or you can speak up out loud. Gina said narrow, sinus
Narrow, yes.
tachycardia.
So it's narrow. Is it regular? Is it irregular?
Gina says regular.
Yeah, okay. So that narrows it down to a few differentials, right? And so the next question is, which one of those? Is it sinus tachycardia? Is it atrioventricular nodal reentrant tachycardia, or what do you think it is? Gina, you got one more shot there.
Do you guys see P waves before every QRS complex? That does help.
Yeah, it could be AFib, yes. That's a good one. It's narrow, but is AFib regular? AFib is usually irregular. So the fact that it's narrow tells you it's supraventricular. It's coming from above the ventricle, right? The fact that it's regular means it's being regulated by the AV node.
Betty says SVT.
Yes. So SVT, you're correct. But so we'll get to that later on. SVT is quite a broad term and it covers quite a lot. SVT, it means it's just supraventricular. You're just describing where it comes from. So that could make it a sinus tachy, it could make it an AVNRT, it could make it like 3 or 4 other differentials. So essentially, when you come down to the narrow and then it's regular, you start looking at the P wave. If there's no P wave, yes, it could be AFib, but it is regular. So this is an atrioventricular node reentrant tachycardia. That's what it is. That differentiation between it and AFib is the fact that there's no P wave, but it is regular, telling you that it does go through the AV node. So this is one of the commonest causes of palpitation in patients with normal hearts, like healthy people. It's typically paroxysmal and just occurs spontaneously, or this is the patient who comes after having some energy drinks and then comes with palpitations, or the patient who has had like a 2-hour period of nebulizations for maybe an asthma. Then they come in and then you see this tachycardia with no P waves. So it's an AVNRT. It's more common in women and than men. And like I said, it's usually you find it in structurally normal hearts and it's paroxysmal and goes away. But we'll talk about management. This was a recap. So the thinking is narrow, yes. Regular, yes. And the next thing is, are there P waves or not? Okay, we'll go to the next one. Yeah. Any takers for this one? So it's narrow or it's not narrow? If we could follow that format to make it much so that we just get used to asking those questions each time you see a weird looking tachyarrhythmia like that.
Gina says narrow, regular, and SVT.
Yes. So SVT again. So like I said, you see the SVT keeps reoccurring, but it's actually an umbrella term for these 3 very common tachydysrhythmias. It's AVNRT, you have AVRT, and SVT could also be a sinus rhythm because it's still supraventricular. So now do we have P waves now?
Gina says no P waves.
No P waves. Okay. All right. So we say it's narrow and it's regular and there are no P waves. So the next thing here is P waves can be very, very deceptive, especially when the rhythm is this fast. So you really have to look. Sometimes you can have retrograde P waves that you don't see readily, but I'll show you a little trick with the ECG leads that you can actually use to accentuate the P waves so you can see them. Then the next thing here is the rate. The rate here looks very, very high. It's quite high for just your normal regular SVT. You can see this is what do you think the rate is? Can anyone just tell us what the rate is?
Almost 300.
Exactly. That rate is almost 300. So that's a lot. It tells you that whatever is happening here is actually not even going through any sort of control from the AV node. So usually you find this when there's an accessory pathway, meaning it goes through another pathway that bypasses the AV node, and that's why you can get up to rates of 300. Sometimes you could have retrograde P waves that are usually visible. Sometimes it's just attached to the QRS complex, so you have to look very well. Sometimes you might just see a little bulge or something, some telltale sign that there are P waves hiding there. So this is actually an atrioventricular reentrant tachycardia, the orthodromic type. There are two types. There's the orthodromic and then there's the antidromic. The orthodromic still appears narrow. It's also regular, but the give here is the rate. The rate is just too high to be your normal sinus tachycardia or AVNRT. It's usually caused because of the accessory pathway, which forms another re-entry circuit between the AV node and that, so it bypasses the AV node and just keeps going round and round and can get up to rates of 200 to even 300. Now, like I mentioned, there are two types, the orthodromic and the antidromic, depending on the direction of conduction. I'm not going to go into detail too much because we've got a lot to cover, but it's something to look up and just see that SVT, that umbrella term SVT, can actually be your AVRTs, your AVNRTs, and you can also even include your sinus tachycardias as a supraventricular tachyarrhythmia. So this is an atrioventricular reentrant tachycardia, the orthodromic type. It's narrow, it's regular, but the rate is usually in the 200s to 300s. The next one. Remember, this is a recap, so we're just running through. It's narrow, it's very weird looking. Is it really narrow, this one?
We have people saying wide complex.
Yes,
Someone says,
wide.
is it antidromic AVRT?
Yes, exactly. So that can be a bit confusing, but we'll talk about that later. So it's wide complex, and we've been talking about narrow complexes for a while now. It's wide complex, but it is regular. And you can see the rate is also in the 300s, between 250 to like 300. So this is the antidromic type, and it can be a bit confusing when you start looking at it, and you might actually think it's a ventricular tachycardia. Same story. It's an accessory pathway, so it's wild. It doesn't have any form of control, and it also can look like a VT. So that's correct. It's antidromic AVRT. Now, I was talking about ways that you can use to accentuate the P wave. One of them is the Lewis lead. The Lewis lead is essentially so the Lewis lead is an ECG lead configuration which helps you to accentuate the P wave voltage, and then it makes it easier to discern the P waves. I don't know how many of you have almost felt you should have a magnifying glass when you look at ECGs, ECGs, especially the rhythm leads, because you're trying to peer into that QRS complex, see if you might just catch that, sneaky P wave hiding there. Now, if you have that difficulty, you can actually use your Lewis lead configuration. Like, for example, in regular narrow complex tachycardias, we talked about now, you can diagnose a sinus tachycardia by the detection of normal upright P waves before every QRS. The definition of sinus rhythm is P wave, QRS followed by, P wave followed by QRS. So, but you could have a rhythm that's so fast that the P waves are not very visible. The Lewis lead can help you accentuate this. Also, in things like regular wide complex tachycardias, you may diagnose a ventricular tachycardia by the presence of P waves, but you see that they are not in consonance with the QRS. So you have AV dissociation effectively. And that could be the clue you need to tell you, okay, this is most likely a ventricular tachycardia because the P wave is just not speaking to the QRS at all. So that's the Lewis lead. I'm going to show you the configuration in the next slide, but I just wanted to look at this ECG now. Now you see initially in this ECG, there are no P waves. It actually looks like, there's nothing here. You can peer at the rhythm lead and you don't see any P waves. But when you repeat that same rhythm strip using the Lewis leads now, you can begin to see the P waves popping up. And after every P wave, there is a QRS, P wave, QRS, P wave, and QRS. And then it tells you that P wave, QRS, P wave, QRS. And then it tells you this is either a sinus rhythm or, some other rhythm that has discernible P waves and then a QRS. So rather than if you had looked up here, the first reaction would be there are no P waves. So the Lewis lead is essentially this configuration here. You take the limb leads effectively. Those are the leads that you change. You leave all other electrodes where they are, and then you place the right arm electrode on the manubrium now. Then you change where the left arm electrode is, put it at the parasternal level, on the fifth intercostal space on the right. Then the leg electrode also, you move them. The left one you take to the right lower costal margin, like the arrow shows there. The key here is you only read lead 1 on your ECG, rhythm lead at this point, and that's when you can get this showing you the P wave here. So you basically increasing the voltage of your P waves so that you can see them if they were like hiding before. It's something you need to just have this picture handy and look at it each time you want to use your Lewis lead. It's not something we do all the time, and so you tend to forget. But this is a nice picture to have that you can always use whenever you need to look for those sneaky P waves. All right. Yeah, next one. Any takers for this one? I just had to put the Lewis lead there just because at that point we were looking at, those fast tachyarrhythmias, which we're trying to guess if they had P waves or no P waves. Any ideas what this one is?
Any guesses on wide or narrow, regular or irregular? We just had someone say narrow, regular.
Yes. Okay, good.
Is it sinus tachycardia or something else?
What do we think? So we're looking at the rhythm lead now. What do we see there? What do we think these are?
Nice. Someone just said P waves are inverted. So is this a sinus rhythm or not?
Yes, that's a very good one. So it's not sinus. It is the P waves being inverted tells you that this rhythm is actually not coming from where it should be coming. So it's coming from an ectopic focus somewhere. So this is an atrial tachycardia. It's also known as a focal atrial tachycardia. Remember, we also have the multifocal type. And
for some reason, Patrick,
yes,
your WhatsApp just
yes.
started sharing instead of your presentation. I'm not sure what happened.
What happened?
Oh no.
Okay.
Click unshare and then reshare. I don't know how that happened. I'm sorry.
What happened now?
Oh,
All right. Are we
there
back?
we go. Yes, you're
Okay.
good.
All right. Okay. So that's an atrial tachycardia. It's not narrow complex. It's regular, but you can see it has consistently abnormal. The keyword there, they're also the morphology is consistent. They're all inverted P waves. And so that's important. So it tells you it's coming from the wrong place. It's not sinus, but it is coming from above. So it's still above the ventricle, but this is an atrial tachycardia from an ectopic focus in the atrium. Next one.
Oh, Patrick, you just
I'm
switched
sorry,
screens
Jess.
again.
I'm sorry.
It must be some button on your keyboard. I'm sorry. I don't know where that's how that's happening. You're good. We can see it now.
You can see it now. All right.
Okay, it just switched again. We're looking at your POCUS book.
Jess, I'm sorry. I think I understand what's happened now. I had a phone call that came in and
oh, okay, no worries. I've had the same thing happen.
It goes to my laptop. Sorry, but I've sorted it out now. All right, so we're still talking about the ECG here. What do we think? Narrow, wide, complex, regular, irregular?
We have several people saying narrow, complex, irregular.
Nice. Yeah. So I see we're getting into that groove now, and that's good. So narrow, complex, irregular. What do we think? I think someone had mentioned it earlier on.
We
So narrow,
have
complex,
votes for
irregular.
AFib here, Patrick, several AFibs.
So the key here is when you've determined it's narrow, complex, irregular, the next thing is you look at the rhythm lead and see, is it sinus? Because that sounds like a sinus rhythm. And you're looking for P waves before every QRS. We don't have that here. So correct, that's AFib. Okay. All right, next one. I've made this one easy. I've actually put guidelines there. Arrows for you to look at.
No guesses yet. People are still looking at it. All right, we have a vote for narrow, complex, irregular.
All right.
Multiple people saying irregular. Someone says MAT.
Yes, that's a good one. Can I just ask why the person said MAT? What's the reason? Why do you think it's an MAT?
Rebecca, why MAT?
The P waves don't look the same.
Yes. So they come from multiple foci. Yes, exactly. So that's the thing there. They come from multiple foci. And usually the definition is you see at least 3 distinct P wave morphologies in the same lead. And you can see those 3 arrows, those are 3 very different looking P waves. So correct, that's an MAT, multifocal atrial tachycardia. All right, next one.
Narrow or wide, regular or irregular. All right, we've got a vote for narrow, regular.
Okay, is it really regular?
Someone says irregular now.
Yeah. Okay. So can we have a vote, regular or irregular?
Looks like the majority are now saying irregular.
Irregular. I think I'm gonna go with the irregular guys. Yeah, so that's narrow and it's irregular. And one trick here is I saw somewhere in the book that you look at leads, the inferior leads, lead 2, lead 3, AVA. If you turn this ECG strip upside down, you can actually see like flutter waves, you know. So this is an atrial flutter, but what's strange about it?
Yeah, we get, someone said irregular conduction or variable response.
Yes, exactly. So it's atrial flutter, but it has an additional block. And if you look at the rhythm strip very carefully, you see that it's the block is regular. It's a 2-to-1 block. Especially when you try to work out what the ventricular rate is. So this is a bit of a harder, ECG to determine, but I just put it there just to show you how you can have a combination of things happening at the same time. So atrial flutter, normally you'd say it's narrow complex, it's regular, but because of the block now it becomes irregular. So just be careful when you're looking at, as we go through that algorithm of narrow complex, wide complex, you need to also know that you could have two things happening simultaneously, and that changes the appearance of the ECG. So this is an atrial flutter with a 2-to-1 block. Correct. Next one. Narrow, wide, regular, irregular.
All right, we have wide, irregular.
Okay.
And then another vote for wide, regular. And then someone more specific who says that it is wide complex, regular monomorphic VTAC. Someone else voted torsades. So we've got things all over the map. We would love for you to go through this one, Patrick.
Okay, so we agree it's wide. We all agree it's wide. Definitely it's wide complex. And the next clue there is monomorphic, meaning just like we talked about earlier on, the morphology is the same all around. So it's one type of, broad complex that we're seeing. So it's a wide complex regular tachycardia, which tells you it's not coming from the SA node. It tells you it's coming from much lower down. So it's originating from the ventricles. And that makes it a monomorphic ventricular tachycardia. You can see the uniform QRS complexes. So that is a monomorphic ventricular tachycardia. Now, you've got to also differentiate this from some SVTs that could have an accessory pathway, what they call an SVT with aberrancies. Sometimes they could appear like this. It's wide, it's regular, but it's actually an SVT just with, an accessory, pathway somewhere that makes it look like a VT. But I think that's a story for another day, differentiating SVT with aberrancy from a VT. It comes with a whole lot of other different algorithms for doing that. But for the purpose of this presentation, this is a monomorphic ventricular tachycardia. Correct. Next one now.
Any guesses of wide or narrow, regular or irregular? All right, finally, we got an answer. Someone says irregular and wide. They think maybe it's AFib with WPW.
Correct. That's hitting the nail on the head. Exactly. So it's AFib with a WPW. Exactly. What's the giveaway there? Why the WPW, if I may ask? It's wide complex is irregular, so yeah, AF, but isn't it supposed to be narrow, probably?
She says accessory pathway, so it makes it
Yes, exactly.
look like
The
this.
accessory pathway, yes. Accessory pathway. And that what gives you your delta wave, isn't it? Yeah, that's the delta wave. You can see that clearly. All right. So that was just a quick recap. I think we went to town a lot. There are a lot of other things, the polymorphic, VTs, your tosas, all the other rhythms, which I didn't bring up here because this was just supposed to be a recap, just to get us back into the flow with the tachyarrhythmias and the algorithm which we taught last time of asking the question: is it narrow? Is it wide? Is it regular or irregular? But today we're going to just have a few cases and then see how to manage this tachyarrhythmias when we get them in as our patients. Okay, the first one is something I'm sure we've seen a couple of times in the emergency department. Young female comes in, no one's sure what's happened. There's probably a suicide WhatsApp message or note somewhere. And empty antidepressant blister packs are found in the bed. And we see the heart rate there. She's tachycardic. BP is soft. BP is there, 102/64. Respiratory is of 20. She's got a bit of a temperature there, 38.1. And she's sitting on room air at 98%. She's examined, she had dilated pupils, flushed skin, and she's a bit confused with a full bladder. This is the ECG. As soon as she arrived, someone was smart enough to recognize and do an ECG for her.
Any interpretations, guys? Is it wide or narrow, regular or irregular? All right, we have a vote for wide, regular. And they say TCA poisoning.
All right, okay. I can see people are a few steps ahead already. Why TCA though? What's the clue there? Is there something on any lead that is quite pathognomonic so that for the people who don't know, they might just be able to see it's quite clear here. Anyone in the chat group?
Well, they're saying because of the anticholinergic toxicity. But how about on the EKG, guys? Do you see anything specific that suggests to you that this could be TCA poisoning?
Wide QT interval.
Okay, but something a bit more like staring you in the face, you know, like
Wide QRS was also put in the chat.
wide QRS, yes.
And then, aha, terminal R wave and AVR.
Yes, exactly. It's poking you in the eye, literally, that R wave. So yes, that's usually the clue there. There's a tachycardia. Patient is confused. She's flushed, and then she's got this EKG. Usually, the diagnosis will be TCA. Yeah, I know it's not usually as obvious as saying she had antidepressants around her. Usually they come with nothing at all. But these are all the things that, kind of like lead you down a specific road, and then you can start thinking of antidotes, because what you want to do is get some kind of idea of what the patient took, looking at toxidromes and getting your data points. And then if there's an antidote for that particular presentation, then you can give that. So yes, this is an example I just wanted to give to show you that tachyarrhythmias are not necessarily of cardiac origin. Sometimes it could be from toxins. So this is a case of a tachycardia. It's caused by a toxin. And the standard approach here would be like for all toxins is you resuscitate the patient first, you re-stratify them, and then you identify from clinical history taking, physical exam, your EKGs, your blood gas, and then you treat if there's a toxidrome. In this case, the antidote would be sodium bicarbonate. And then there's the whole thing about the QRS complexes and when you give. But I'm not going to go too much into detail. I just wanted to highlight the fact that tachyarrhythmias can occur from extracardiac sources also. Okay, this was a second case. 62-year-old male, he comes in, he's got sudden palpitation, got some mild chest tightness. He's lightheaded, but talking to you, giving you the history. And you find out he's got the background of a previous EMI, had been to a cardiologist before, even had an echo with an EF of 35%. And his chronic medication, he's on a beta blocker, enalapril. He's tachycardic, borderline shocked to respiratory of 22, and is saturating 95% of air.
Patrick, sorry to interrupt you. I'm wondering if you can go back one slide and just point out the terminal R wave with your mouse in AVR or with the pen feature.
Yes.
Gina is asking. Thank you so much.
Yes. So that's the terminal R wave we're talking about. And it's on AVR. So it's terminal R wave. You can see normally you don't have an upright, dominant R wave like this on AVR. So that's what you have here. Is that clear to see? Yeah. So the other things we have, the wide QRS, the QT, but this is quite prominent. You don't have this normally on EKGs. Okay.
Patrick, please, could I say something?
Yes.
Are you able to show the delta wave in the penultimate one, tracing the one of the
WPW?
Yes, perfect. Thank you. Sorry to take us back.
No, it's fine. So the delta wave is here. You can see that. That's the delta wave.
Great. Thank you.
All right. So we see those vitals, and the next thing is we need to do something for this patient. He's not shocked particularly, but he's getting there. You'll have to calculate a shock index for him, and that will be quite high if you look at his heart rate and his blood pressure there. He's already lightheaded, but he's still GCS 15. What do we think the next line of management should be? And he's running a tachy of 168.
All right, there's messages here that this patient is unstable. Concerned that we need electricity.
Okay, that's fine. Does anybody else have any different opinions? Should we bust out the paddles and electrocute this patient?
We do see one suggestion of trying some fluids first before electricity.
Okay. That's all right. That goes with the whole, trying to resuscitate the patient, but I'd say judicious fluids, because you already see his ejection fractures are not great. You know, 62 ejection fraction, not too great. So you'd want to be very judicious with your fluids. All right, those are very good opinions. And Charles, I didn't show his ECG. Did I show this ECG already? I just showed the question. Sorry,
No.
guys. Sorry.
But it doesn't change the answer.
It doesn't, exactly. It doesn't change the answer. True. That's his ECG. And I'm sure we've seen this ECG previously, and we all know what it is. So yes, this patient will benefit from chemical cardioversion too. I know we said electricity, you know, but if you stick to the letter, you should actually still be able to benefit from chemical cardioversion. But this could generate a lot of argument. That's why I put it there. It depends on what the protocols and what, you know, the practice is in your center. And it's very important here that you should differentiate ventricular tachycardia from an SVT with aberrancy, because that could very well change your management plan. If it's a VT like we've seen here, this kind of VT, I would probably just, you know, electrically cardiovert this patient, especially given the history that he's got previous MIs, ejection fraction is low. I'd probably just shock the patient. So that's correct. But you wouldn't be wrong if you also start chemical cardioversion. You could use amiodarone initially, but procainamide would be the best, especially because of that lowish BP and that high shock index. Jess, what do you think? What do you do over there? What would you have done for this patient?
Yeah, great question. For the unstable patient, I do usually go with electricity. I would have had no problem starting some fluids right off the bat to see if we could at least get the heart rate to slow down a little bit or temporize the blood pressure while we're getting the electricity set up. Some people in the chat here said medical cardioversion, synchronized DC cardioversion. So it sounds like most people agree, like this patient's unstable, they're hypotensive, they have chest pain. It's probably VTAC since they have a history of MI. So I think I would agree with most people here that I would lean on the side of electricity if I think it's VTAC and if a patient's unstable.
Yes, I would probably too. Especially like I highlighted there, you should use your history, clinical examination, and then the ECG information to make that decision. All right, I think we all agree. Synchronized electrical cardioversion, but there's also a place for chemical cardioversion. Knowing that if that fails, then you should electrically cardiovert the patient. And third case. So this is that young guy who's been to the gym, and I think it was one of those open days at the gym. He hasn't had a gym membership, so he just decides to go in and go all out. He's brought in now. He's suddenly collapsed during the workout. He's unconscious. He's agitated. He's also short of breath. He's got a tachycardia of 198. BP is definitely shocked with a systolic of 78. He's tachypneic and is saturated at 88 on room air, despite the oxygen from a non-rebreather mask. Temperature is normal. He's pale, clammy. Essentially, he's in shock. Treatment here would be I think this one is quite obvious.
Yeah, everyone's saying unstable,
Yes.
fluids and electricity.
Exactly. That's his ECG, which doesn't change anything. We're looking clinically now. This patient is the typical example of an unstable tachycardia, and the treatment will be electricity straight off the bat. And that will be your first modality of treatment. Exactly. All right, we all agree. I hope we all agree here. There's no dissent. I'm sure we all agree. All right. So, just broadly, I just wanted to talk about like the tachycardic patient and some of the clinical features and things we should look out for. I just use the 3 cases just to highlight how they could present in the various ways. So first of all, it's essential to take a clinical history. That is usually your first guide. I mean, while somebody else is setting up the ECG machine and putting up the electrodes, a clinical history is very important. Like the previous case where you had a previous MR, EF of 35, those things kind of like give you an idea of what kind of tachycardia you're dealing with, as opposed to a young 38, 28-year-old male who just went to the gym and then collapsed and has a tachycardia. Also, the probability of him having a structurally normal heart is there, as against someone who has a previous MI. You know that heart is not operating optimally and is even got an EF of 35. ECG is the most important diagnostic tool. You should have that stat as soon as the patient comes in and you've seen that he has a tachycardia. A bedside focus in places where there are people who, can use a probe can come in very handy also, especially with the tachyarrhythmias. It can provide lots of information that can help determine in what direction your management would go. And then you can add the laboratory and imaging, which personally I think doesn't do much. But yeah, like I said, you could also have tachyarrhythmias coming from, non-cardiac sources. That's where your lab and imaging could help. So we talked about the young male who had come in, was unstable, and we had decided to electrically cardiovert him. Cardioversion usually, before 2025 AHA guidelines, they usually said just give the electricity according to whatever the manufacturer advises. But now they've come out with a few guidelines now. The 2025 AHA guidelines kind of gives specific voltages that you could use for different kinds of tachycardias now. So for like narrow or monomorphic VTs, you are advised to use 100 joules. And then for like atrial fibrillation or flutter, which are a bit harder to cardiovert, you go up to 200 joules actually. And if you have polymorphic VTs like the ones we've seen here, you could just defibrillate. That's unsynchronized cardioversion actually. So you obtain consent. Usually you need to give this patient some moderate analgesia, sometimes just a bit of sedation, even though you need to be judicious here because you don't also want to, cloud their mentation at that point in time, because that's also, some of the parameters you use to see how stable or unstable your patient is. So you want to just give some moderate and everything in moderation here, even your fluids. And then you deliver the shock. You continue close monitoring of these patients, and they usually end up with cardiology. If you get sinus rhythm back, the patient you still monitor. Sometimes you can have a recurrence of the same dysrhythmia, so you continue close monitoring. Usually they're kept in, your monitors beds or your monitoring area until cardiology gets to see them and makes a decision as to what to do next. These are just broad outlines of managing for the unstable tachycardias. Any comments here? Do we do something else differently somewhere in the other centers?
Patrick, I did just want to comment, and this is such important information. You mentioned this has to be synchronized cardioversion because you want to avoid that R on T phenomenon. So if you don't synchronize and you accidentally defibrillate the patient, that can put them into ventricular fibrillation and lead to death. So make sure for the patient who's not in cardiac arrest, the awake, alive patient who's got a ventricular tachycardia or another unstable rhythm, it's synchronized cardioversion. And then most guidelines do not recommend starting anticoagulation after you do synchronized cardioversion for ventricular tachycardia. Unlike atrial fibrillation, those patients are at really high risk for a stroke after cardioversion, and many guidelines suggest doing anticoagulation for several weeks afterward. So I don't know what the protocols are at each of your hospitals, but where I work, we usually do about 3 to 4 weeks of anticoagulation after cardioversion for atrial fibrillation, but not necessarily for ventricular tachycardia. Patrick, does that differ where you work?
I think it's the same thing, but we do a shorter course for the anticoagulant. I think it's 2 weeks, and then usually by that time they're all with the cardiology guys. But yeah, it's about 2 weeks.
Perfect. Awesome. And if people do different things at their shops, please do chime in the chat. We'd love to hear what's different where you work.
Yeah. All right, and then we go up to the stable tachycardias. The unstable ones is quite obvious. It's unstable, you shock the patient and that's it. But for the stable one, there are a few nuances here and there, depending on what kind of rhythm you have. So for like the paroxysmal VTs, you can start with vagal maneuvers. I'm sure we all know the modified Valsalva. And in pediatrics, usually you use an ice bag and put it over the face. That usually, I've seen that happen so many times. It usually works quite beautifully, actually, with the kiddies. And there's a revert maneuver. It's just a nice fancy name for the modified Valsalva, where the patient blows, you try to ask the patient to blow into a syringe and blow out the plunger of the syringe for about 15 seconds while sitting up. And then you make them lie down and you raise up their legs for another 15 seconds again. And this kind of stimulates your vagus nerve, and you see if that can help with, returning the rhythm back to sinus. If that doesn't work, then you can go up to amiodarone. That's your next option now.
Just
No,
one
that's
quick thing to note, Patrick. Remember everyone that vagal maneuvers are always great to try first, but that they're less likely to work for a ventricular tachycardia than for a supraventricular tachycardia. So it's still worth a shot, especially in case it is a supraventricular tachycardia with aberrancy, meaning like there's a bundle branch block or an accessory pathway or something like that. So you should try it first, but just realize if it's true ventricular tachycardia, it may not work, since the vagus nerve usually hits the AV node and it doesn't really work directly on the ventricles.
Yes. Oh, thanks, Jess. That's actually true. That's very important. Just to note there, that's a typographical error, please. That's adenosine, not amiodarone. The next drug there, that's adenosine. I'm going to correct that before it goes.
I'll fix it in the slides before we send them out.
Yeah, please. So I just looked at it now. It didn't make sense. Yes. So adenosine is your next modality that you can use. You give 6 milligrams of rapid intravenous dose, and then you give a quick rapid flush also. Best if you can use, the Y connector, where you can have 2 ports and then you fix your syringes to both ports. So as soon as you push the adenosine in, you can just push the flush in, and remember to raise the limb up so that it goes straight to the heart. What this does is sort of stuns the heart back, and hopefully that makes it revert back to a sinus rhythm. If there's no response, you can increase the dose to 12 milligrams IV push also. That usually will work if you increase it. Then there are other tachyarrhythmias, like we've seen. There's so many, and usually you have to look for and treat the underlying cause. So that's the bottom line. After you've done the emergency, treatment or maneuvers, you need to look for and treat whatever is causing the tachyarrhythmia. Sometimes it might be a primary cardiac problem, which needs, cardiology intervention. And usually that's done later on. But you need to also have an idea of what could be causing, this tachyarrhythmia right after you've done the emergency intervention. Okay, just a reminder here that when you're doing this procedure, these patients could very, very easily crash, and you could, end up in situations where, there's a loss of a pulse and you need to actually go straight into CPR. So always have a crash cart available when you do these things, when you're trying to convert cardiovert patients. And because sometimes when adenosine, you give the adenosine, they could actually just crash, and that changes the whole picture. So just remember, whenever you want to do these things, have your crash cart ready. And you've briefed your team at what complications could occur, and everybody has holds, and everybody knows what to do if the patient crashes. All right, so that sort of ends that piece about what to do and manage with these patients. I tried to look for some kind of literature that could also tie in with this topic. And I saw this very interesting study in the Lancet. I think we can all just look at it and possibly copy it, and I think it'd be a nice read for us later on. So we're just going to look at the study and try to see, just appraise it and see how important it is, what limitations it has, and what information it had for us at the end of the day. So the methods was conducted in 11 Canadian academic emergency departments. It had adults with acute atrial fibrillation that were enrolled in the study, and it had two protocols. One was a drug strategy where they had patients just receive drugs alone, IV prokenamide, or even electrical cardioversion if needed. And they gave a placebo infusion also. Now, they were all randomized, double-blinded, and the placebo was controlled. The second protocol was they only shocked the patient. It was randomized, open label, but they used two types of pad positioning for this electrical cardioversion. The popular way we use the pads is anterolateral pad positioning. So what they did was, for some patients, they used the anterolateral position, and for some, they put it anterior and posteriorly. Protocol was 1:1 for the first protocol, and the second one was they performed 30 minutes post-infusion if there was no conversion following, the shock strategy. Let's see what they got from there. The aim was actually to just compare the conversion to sinus rhythm of tachyarrhythmias between when you give just pharmacological agents and if you give a pharmacological agent followed by electrical cardioversion. So drug and then shock, or just shock alone. Then the secondary aim was, like I said, they tried to see what, the conversion rates, if they were different between the two types of pad position, either anterior lateral, or if you position the pads anterior and posterior, there'll be a difference in the conversion rates. The results were basically that there was not really much difference. Both the drug to shock and the shock alone strategies, they were safe, they were quite effective. The good thing was that it avoided the need for patients to return to the hospital because they were quite effective in converting the patients. It also showed high rates of sinus rhythm restoration in ED patients with acute atrial fibrillation. For the pharmacological ones where they used the drug was successful in approximately 50% of them, and it's also reduced the need for, all the things that you need when you want to electrically cardiovert the patient. Remember, we talked about signing consent, sedating the patient, analgesia, and then these patients still need to be monitored post-conversion because you've given analgesia, you've given agents that could rightly affect the already altered physiology of these patients. So it was quite resource intensive. For the electrical cardioversion one, there was no significant difference in success between the two types of pad positions. So basically, they gave the same results at the end. And the whole implication of this was that there was a high, good outcomes that came from converting these patients using both methods and using both pad positions. But there were still some limitations to the study, and I've just highlighted some of them. I'm sure after you guys also go and look at the study, I'm sure you might also have picked up some limitation. Like every study, no study is perfect. The selection of patients was quite strict. It was just acute atrial fibrillation patients, and so this made it a narrow subset of patients that could be included in the study. So it excluded people with like unstable atrial fibrillation, people who had acute coronary syndromes, just focus on stable primary acute AF patients. The other thing is, if you look at the algorithm for tachyarrhythmias, there are a few antiarrhythmics mentioned. One example is amiodarone, but in this study, they only used ivory procainamide. So this was also a limitation because you can't find that very readily. I'm not sure how many hospitals in Africa have procainamide readily available. But essentially, the high success rate also was a bit, it was a bit, limiting also because already there's high conversion rates when you use electrical cardioversion or uses pharmacological agents. So we've already had a high conversion rate already. So adding the ceiling effect is essentially just means this thing was working before. And so adding extra, drug shock or changing the pad position doesn't really seem to, add any therapeutic effect. This is a concept in pharmacology where, when you add drug dosage beyond a certain point, it doesn't produce any therapeutic effect again. So that's kind of like what happened here. These methods have been working before. So changing the pad position or giving drug and shock or shock alone doesn't really tell us much because already we have a high conversion rate. So I felt that was also quite a limitation to the study. It didn't really add anything new, so to say. Yeah, like I said, I don't know if anybody else would have any limitations. Right? I don't think people have looked at the study yet, but if anybody has looked at it while I was talking, we could actually just say something of what you think. One of the big ones for me also was the fact that the procainamide path, like I spoke about, I think I wouldn't be stretching it too far if I say most of the hospitals in Africa would have amiodarone more readily available than procainamide. So I would have preferred a study where a drug like like amiodarone is used, and that would have given me a lot more information. So locally, it doesn't really speak to my practice.
Yeah, and I was just typing in the chat too, Patrick. I've worked at several hospitals that didn't have procainamide here in the United States. So not everyone's
Oh,
going to have
really?
this drug. Yeah. You would
And
think
even the
everyone.
US?
Yeah, I've worked at several community hospitals that don't have it. I'm sure at my university hospital, we probably do. And it's a great choice of a drug if you have it, if you have any suspicion that this person has underlying WPW or like an accessory pathway. But not everywhere is going to have that drug. So I would just be cautious. If you think someone may have, an accessory pathway or WPW, amiodarone is going to block the AV node, just like beta blockers and calcium channel blockers. And it could potentially lead to more of those signals from the atria going through the accessory pathway. So if you have any concerns for an accessory pathway, it's better to just cardiovert them rather than do the chemicals. I don't know if you have different thoughts, Patrick.
Well, I totally agree. And like we've said here, it's quite safe and it's effective. So if you have any doubts at all, I mean, all the guidelines say that. If you have any doubts and it's wide complex, it looks like a VT, it smells like a VT, just I would rather just electrically cardiovert the patient. That being said, Jess, I know we're talking about tachyarrhythmia, but amiodarone on its own as a drug, it has a whole litany of things that it could do. It could actually do
Indeed.
the things that we call it a dirty drug here. It's got so many downsides that I sometimes wonder if we should actually be using it. But that being said, that's what we have. So I'd rather shock the patient than play around with amiodarone and risk, like you said, blocking the pathway for the patient.
Yeah, 100% agree. Amiodarone is kind of a dirty drug. It's like tramadol or diphenhydramine. There's just a list of drugs that hit almost every receptor. So you have to be really careful.
Really careful. You have to really know what you're doing. All right. Does anyone have any other limitations that they think for this study? Or can I move on? Is there anything in the chat, Jess?
No, not at this time, Patrick. But if people have questions, please do feel free to put them in there while he goes through his take-home points. And I'm going to launch the post MCQ. Oh, Bernard just said electricity is readily available. The only current challenge is the myths and misconceptions. Bernard, can you touch on that a little bit more or expand on that?
Yeah, I think that emergency medicine just still being very new in the specialty, seeing you electrocardiovert or electro, defibrillator or that on the ED is kind of still very, very, a lot of the other staff and health workers find it. You will first have a big argument before you even convince people that this is the right thing to do. Both the health workers, but also the family getting consent to do that. So it's still has that kind of a challenge.
Oh. So my take on that is sometimes those scenarios are opportunities for emergency medicine to earn its stripes, because the people who are worried or anxious about what you want to do don't actually have a better solution for you. And here's a patient who's obviously not doing very well. So this is a patient that if you can get across to the family or get consent and you shock this patient and it gets better, you've earned 2 or 3 more converts to emergency medicine. So if you think it's needed and you're sure of what you're doing, well, okay, you're not 100% sure in emergency medicine, but you've looked at everything and this looks like a patient that will benefit from electrical cardioversion. I think you can go ahead and you can actually shatter those myths slowly with 1 patient, 2 patients that you actually help, and then people begin to actually appreciate what you've done, and the next time they'll call you when there's a patient like that. So I think rather than be deterred by colleagues, I think we should actually try to win them over by doing this this so-called strange or new therapies that people are not used to. I don't know what you think, Jess.
Yeah, no, it's honestly the same thing here sometimes, Bernard and Patrick, where I tell someone, hey, you're really sick and unstable right now, and I think we need to use electricity to help get you out of this funky rhythm. And there's always this wide-eyed look of shock and fear. They're like, you're going to shock me? And I think we just need to normalize it. And it's across cultures that this is a scary thing. I mean, people watch TV and see dead people getting shocked. And so I think just explaining to them that this is a safe procedure and we're going to give you medicine to help you not feel pain and not remember this experience. Just keeping a calm voice and helping provide reassurance that this is standard of care is really the best thing that we can do. Yeah, Bernard says it's getting better over time. And I think same here, but it takes a little convincing because it is a scary thing to have someone tell you they're going to shock you. But I think just normalizing it.
Okay. So I just also touched on the 2025 AHA ACLS guidelines. There were a few changes there that I felt were it's a whole, there's like 1,001 things there, but I just kind of got out things that related to tachycardias, because there were a few changes here and there. If you see the first one in the 2020 guidelines, it still uses SVT as a main umbrella term. But now in the 2025 guideline, it doesn't use the term SVT anymore. Now it says narrow complex tachycardia. They're trying to be a bit more specific now. So that's why I kept saying SVT actually is an umbrella term for like 3 or 4 different types of tachycardias. So now it's better to say it's a narrow complex or broad complex, just like we've tried to learn in these 2 sessions. The other thing was sotalol has also been downgraded. It's not used anymore in adults. Adult VF or pulseless VT. It's been removed. So, but you find it in pediatrics. Still has a place in pediatric tachyarrhythmias, but not in the adult one anymore. Rather, it keeps adenosine, amiodarone, and procainamide. Like I said before, initially it used to be you use energy settings by your device. If you use a Zoll or whatever kind of defibrillator you have, they usually came with recommended energy settings. But now they've given specific energy settings for different tachyarrhythmias. I think I read out some of the ones, like narrow monomorphic VTs, they recommend 100 joules. For like AF and flutters, 200, because they are harder to cardiovert. They recommend 200 joules. So they're a bit more specific now in the new guidelines. The mindset is more mechanism driven. What's driving this tachyarrhythmia? And it's no more mechanism driven. Sorry. Now it takes ECG morphology, how the patient is, into consideration, and energy giving electricity is also advocated a lot more now, and the approach is a lot clearer now. I'm not saying go read up the manual of your device to find out how much energy to give. So there's much more clearance now on electrical therapy, and just having so many antiarrhythmics like in the previous ones is discouraged now. It's more more specific now, which is actually good for the low resource settings, because like we just said, we don't have a lot of those fancy drugs. We have very few, and if they are seen to be working, then they should be put in the guidelines so that we can all use them, get good outcomes at the end. So I just wanted to touch on that. It's a whole thing to go online and look at. It's very interesting. It touches everything. It's ACLS, so it touches your bradycardias, tachycardias, everything about ACLS. There are few changes here and there. I just wanted to highlight that here so that we could all go look at it. It's quite interesting. Yeah, does anybody have like a standard operating procedure, anything, protocol for tachyarrhythmias? I know we just follow the ACLS principles and that's it. Do you have anything in your hospitals, Uganda, Nigeria? Do you have protocols that are a bit different from what ACLS says? Yes, I'm sure you use the same. Anyway, it comes from you guys, so it's got to be the same.
Yeah, we pretty much just follow the guidelines that you just went
Follow the
over.
guidelines.
We don't have an institutional protocol that's separate from that. I actually did go through the Uganda and Gambia clinical guidelines, and they didn't have anything about tachydysrhythmias in them. So it didn't look like there was any national protocol for either country.
We have a nice South African Resuscitation Council, and they haven't said anything about tachyarrhythmias. We just follow the same ACLS guidelines. So yeah, so basically we're going to wrap up the tachycardia. It's been a long journey for 2 sessions now, and I think it just boils down to a few things. We talked about drug therapy. We talked about shocking the patient. We talked about how to try to differentiate tachyarrhythmias from narrow to wide to regular, to just putting them into those classes kind of helps you narrow down what you think is happening to the patient. And the urgency of your management depends a lot on the stability. You saw the cases we had, the patients who had like shock BPs or high shock indexes. Everybody on the group said to shock them. So stability determines the urgency of your treatment. If the complex is wide, it's VT until proven otherwise. So if it's VT and they're unstable, you shock. If it's regular and it's wide, think an accessory pathway. So think WPW, and you do not give them antiarrhythmics or blockers, because like Jess said, that will block the only pathway they had, and they usually crash after that. Always have your crash card ready when you're dealing with these patients, because the clinical scenario could change very quickly. Treat the patient, not just the ECG. Yes, we've gone through ECGs. It's been very interesting, and it's nice to try to interpret ECGs, but what you have in front of you is a patient who's got the history, clinical exam, and other things that you've done. So you treat that patient and not just the ECG. The ECG is just an additional data point for you to determine what to do for the patient. And don't forget to correct the underlying causes. There are a lot of non-cardiac causes of tachyarrhythmias that you can just correct, and you don't need to resort to electrical cardioversion or antiarrhythmics. So yes, thank you very much. And yeah, I think just keep looking at ECGs. The thing with tachyarrhythmias is just keep looking at every ECG, applying the same steps like we've said now. Just be systematic, and you'll get so used to them that you can, at a glance, you can usually tell what's happening. So thank you very much, everyone. Some of my references, and yeah.
Patrick, thank you for the fantastic presentation. We really appreciate an immense amount of your time between this session and the first one. If you guys can fill out the evaluation link, we would be deeply appreciative, so we know how we can continue to make this better for you. I'm going to go through the post multiple choice questions really quick, and then we'll wrap up the session for the day. The first question was, what is the most important first step when managing a patient with tachycardia in the emergency department? And the answer was assess patient stability. I think Patrick really emphasized that today, that it's more important to see, are they stable or unstable before you figure out the rhythm. So if they're unstable, you need to get the crash cart right away, consider electricity, temporize them with some IV fluids. Once you've worked on getting some stability going, really focus on what's that rhythm. And frankly, if you don't know what it is and you're concerned it might be ventricular tachycardia, or you're really not sure at all, and they're very tachycardic and sick, it's better to err on the side of electricity. The second question was, a patient with tachycardia is hypotensive, diaphoretic, and confused. What's the most appropriate initial management? And everyone got this right. It was synchronized electrical cardioversion. So electricity first for the sick, unstable patient. Question 3, everyone also got right. Which of the following is an appropriate first line treatment for stable, regular, narrow, complex tachycardia? And the answer was vagal maneuvers. So you can try that first. The next question, which statement best reflects safe ED management principles for wide complex tachycardia? And everyone got that right too. Assume ventricular tachycardia until proven otherwise. And the last question, in a stable patient with AFib and known time of onset 6 hours ago, which management approach is supported by evidence? The answer was immediate rhythm control with pharmacologic or electrical cardioversion. If it's been honestly less than 48 hours since the onset of symptoms and the patient is very much sure of when their symptoms started, you don't need to worry about anticoagulation before rhythm control. You just go ahead and shock them or do pharmacologic cardioversion with an agent like procainamide or amiodarone, whatever you have available to you. Especially if you don't have electrical cardioversion, those agents are fine to try. We did mention that most guidelines recommend somewhere between 2 and 4 weeks of anticoagulation after cardioversion, but only for AFib, not ventricular tachycardia. It looks like someone did answer observation only, as most revert spontaneously. Not necessarily true for atrial fibrillation, and the longer that someone's in atrial fibrillation, the harder it is to get them out of it. So ideally, you want to do chemical or electrical cardioversion for that stable patient so that you don't risk them being in permanent atrial fibrillation. I want to thank Patrick again for his time. This was a wonderful session. We will share the recording as well as the summary document. And as a reminder, these summary documents do get uploaded to the CMES library for those of you who have a device at your institution. Patrick, anything else you want to add before we close up for the day?
I think the only thing I have to say here is a big thank you to you, Jess. I think this is a very laudable, objective of yours, and I hope it's, that initial step that will spread to a lot of other countries in Africa where they don't have this opportunity to hear things like this. This has been something I've always thought about, after seeing what emergency medicine does in a place like this. I've always thought about how to transfer this kind of knowledge to places where it's much needed and they don't have the exposure and the opportunity. And I want to say a big thank you to you and your team for even thinking about this. But it's a two-way street. Also, all the people who have come here and have been eager to participate, to attend and to listen. It shows that there's a lot of, enthusiasm and need on the other side also, and that just makes me want to also come here and give in more and more and more. And I say thank you to everybody for making this project, worthwhile and for keeping it going for this long. It's been on for much longer than before I even came here to present. And I'm happy to see that it's growing even bigger. So thank you, Jess. Thank you very much.
Absolutely. Thank you, Patrick. And a big shout out to all of the people who are participating in the chat and out loud. I would encourage you to continue trying to answer questions from the presenters, even if you're wrong. It's a great way for all of us to learn together. It does look like there is one question in the chat before we wrap up. Betty asked, in a patient with a heart rate of 150 but stable vitals, what specific ECG or exam findings help you differentiate sinus tachycardia from SVT before using adenosine? Is it only the absence of P waves? And Patrick, you're more than welcome to answer that question, or I would be happy to.
I'm trying to extricate what the real question is. So it's a it's a 150 beats per minute heart rate with an ECG that has P waves.
She's asking, how do you tell if it's sinus tachycardia versus SVT? Is it just the absence of P waves, or are there any other features that could help you distinguish?
Okay, so it's basically, first, is it narrow or is it like, go back again? Is it narrow? Is it regular? It's narrow, it's regular, it has a P wave before every QRS, it's sinus. It tells you it's coming from the right place. It tells you it's going down the right channels, the AV node, and that's why it has a P wave, and then there's a QRS complex. So that tells you it's sinus. That alone tells you. But if any of these things are not in place, then it's not sinus. And then you start trying to work out what it could be. So those three elements have to be in place. It's narrow, it's coming from above the ventricles, it's regular, it's being regulated by the AV node. There's a P before a QRS. It means it comes from the atrium and then goes down the normal pathway. There's no accessory pathway, and that tells you it's sinus. So that's what you need. Is it sinus or not? If it's not sinus, then you go down, asking other questions to try to find out what it could be. But if those three elements are in place, then it's sinus.
That's great, Patrick. And yeah, no, that's perfect. And then I think I would add too, if it's so fast that you can't really tell if there's P waves, you can always try a vagal maneuver, or you could try some IV fluids to slow things down a little bit. And sometimes that does bring the P waves out if it is a sinus tachycardia. All right, guys, we're going to wrap up our meeting for the day. Thank you again to Patrick. And we had some requests from users for a session on DKA, diabetic ketoacidosis, and HHS for next month, for May. If you're interested in being a presenter for that session, please message me on WhatsApp. I'm just going to put my phone number in the chat one more time. And we're going to wrap up. Thank you all. Thanks, Patrick.
Thank you. Okay, thank you very much, Jess. Okay, bye.
All right. Thanks. Bye-bye.